being with us this evening. My name is Marianne Huff, and I am the president and CEO of the Mental Health Association in Michigan. We want to thank you for joining us this evening for this webinar. This is the third and final webinar in a series of 3 webinars that we've had. The first one was March 9th, and that webinar focused on, basically, why do we need to think about integrated care? Sort of an open discussion about integrated care with some data, because we had done a poll of participants. There was a survey, and so tonight we want to share that with you. The second webinar was an overview and basically an explanation of what integrated care is. And tonight is kind of like an amalgamation of those first 2 webinars. For those of you that have been to all 3 webinars, you know that the third one was supposed to be sort of a wrap up of what was talked about during the first 2 webinars. I also want to say that the intention for these webinars has been to educate people, the average Joe or Joanne, about what integrated care is or is not. It's not focused on anything of a political nature. At MHAM, we've been working on concepts of integrated care, and we will sort of talk a little bit about that at the very end of the webinar. Tonight, we're going to be looking at different models of integrated care, including a report from April Marvin Briggs about integrated care model that is used in the United Kingdom as part of the national health system. She's done a lot of research in that area. She did a lot of research when she was practicing her internship last year with MHAM. She also will be talking about the results of the survey that she conducted during the first webinar, which I think you'll find the results to be very fascinating. We also have Dr. Angela Pinero. She's going to be talking about a paper that was released last month by the National Council for Mental Well-Being. And that paper outlines an approach to integrated care. It's a framework. And so she will be discussing that. She will also be talking about not only major elements of the paper, but also implementation. The paper is called the Comprehensive Healthcare Integrated Framework. So we think that will be of great interest to you, because we believe that this paper can be instrumental in informing public policy for our state. Finally, I'm going to be talking about the policy implications for the state of Michigan regarding integrated care. And I'm talking across all health systems, not just particularly community mental health, but across the entire healthcare system, and to look at ways that our state can ensure that healthcare is integrated. As you know, we've been talking about integrated care for a long time. It's been a subject of great controversy in our state. We wanted to provide education to participants and also to look at it purely from the perspective of how do we provide the best, highest quality overall healthcare. When I say healthcare, I mean physical and behavioral health, because they're not mutually exclusive. How do we do that to everybody, all Michigan citizens, particularly for MHAM, those who have any degree of severity of behavioral health condition or substance use disorder? So before we begin, I would like to introduce our distinguished panelists. We're privileged to have both of these individuals as part of our discussions. First, I'd like to introduce Dr. Angela Pinero, MD. Dr. Pinero graduated from the Michigan State University Psychiatry Residency Program in 1990. She subsequently obtained her Juris Doctor from Michigan State University College of Law. She has worked in the community mental health system for over 32 years as a psychiatrist and is currently the medical director at CMH for Central Michigan. She's an active member of the Medical Director Institute at the National Council for Mental Well-Being and is a certified psychiatric trainer in Michigan's first episode psychosis program. Prior to entering psychiatry, Dr. Pinero was in an internal medicine residency program, giving her a sound platform to understand the need for integrated care. April Briggs is actually a senior at the University of Michigan Dearborn, majoring in communications with a minor in political science. She is passionate about mental health and helping people get the help they need and deserve. As an intern in year 2021 with MHAM, she focused on a large project surrounding integrated healthcare. She developed a survey. She collected data and opinions from people in all areas of Michigan to research on successful integrated healthcare programs, both internationally and in other areas of our country. This research, combined with the data she collected, can help to give a better understanding of what the people of Michigan want in terms of integrated care and how we can implement the positives from other integrated care health systems. So our presentation will begin with April talking about the results of the survey from the first webinar. And she will also talk about the integrated care system in the United Kingdom.
Great. Well, thank you so much, Marianne, and hello, everyone. I'm going to actually share my screen now. We've got a little presentation. It'll be brief. As Marianne said, in my time with MHAM, I was continuously researching different integrated care programs, both in our own country and across borders. And after zeroing in on England and the integrated care systems, or ICSs that they call there, I was able to focus on the system itself and all of its moving parts. So how it came to be, how it became so successful, and really focusing on person-centered care. So today, I'd just like to take a few minutes to overview the National Health Service in England and their ICSs. I want to review their fundamentals, facts, and how they got to a system that is now in every state in their country, and how that helps us in providing plans for us to move forward here in Michigan with integrated care. So in talking about integrated care, it's important not to forget the whys behind it, which are the people served. For ICS, it's fundamentally about improving the system for the people towards a fully healthy population that includes physical and behavioral health in tandem. It's important to address and to work to eliminate the inequalities that exist in the system so everyone receives the same care and same opportunity to care. And continuous development is key for these ICSs. In widening the lens to include everyone in the system, there becomes a better system for society. So in providing resources, smartly using funding, and developing stronger supports both inside and outside of the system. Finally, with collaboration of care in a changing model, supporting staff through proper training is really key. So updating systems, providing time and funding to medical staffs, and ensuring higher productivity, which in turn increases the value of the system to the people, the professionals, and the state. So what is NHS and ICS, and what are their focuses? A brief overview. The National Health Service is a state-funded system that ensures care for all residents across Britain. Currently, there are 42 integrated care systems across the country that are working models of what integrated physical and behavioral health care looks like and how it can be successful nationwide. Providing ample locations is a key focus, and there are several across the country that are accessible to all. They provide integration in one place, and they're spread evenly amongst the states, and they also depend on the population in each area that they are. A bottom-up mentality involves considering the patient and their experience first, and then moving towards the top with that feedback at the top of mind. Policies and procedures in ICSs are drafted considering the patient perspective first and foremost. Funding is supported by the state, but in collaboration, different sectors work together to share their own resources across care. There becomes a real shift in the medical world and the transferring of power through each provider to ensure collaboration and continuity of care for the patient. It is a shift from the strictly service-based delivery care to shared decision-making that involves the patient at all levels. The person served is provided all necessary resources in ICSs, from visits to referrals, first response services, safe haven cafes, in-home visits, in-home emergency response visits, housing, food, and social resources. There's a real focus to care for patients beyond the four walls of the provider's office. ICSs have come up with some very innovative support systems and resources for their people. In terms of how decisions are made for the system, advisory boards are relied on to provide feedback and suggestions. These are comprised of physicians, professionals in the field, and the patients themselves or their caregivers, and they act as guidance in the ICS systems. There's an overall heavy emphasis on the input of the patient through all of this, which is key with ICSs. One of the main success indicators for ICSs is how the patients are doing and how they feel with their care. The most important question, how did they do it throughout their whole country? How did they implement integrated care? So here's a quick timeline. In 2014, NHS proposed triple integration. So that was between hospitals and primary care, NHS and social care, and physical and mental health care. In 2016, all parts of England began planning integrated care systems. It was a real collaboration with NHS providers and their local governments. This planning led to the availability to now share resources and funding across all sectors, as more places were working together and seeing impacts of collaboration, which affected funding. In 2018, the first operating ICS locations were opened in England, which led to an outline for other ICS locations. This included best practices, ideas on collaboration, and setting a clear line of standards based on the patient outcomes and input from persons served, their families, and the actual treating physicians. 2019 included plans on how to integrate the entire country by April of 2021. Which included a strong legislative push to unblock policy and remove the biases in the medical field. This push towards the government was largely influenced by consensus from operating ICSs. It included reports and opinions, outcome surveys, and suggestions by advocacy groups, health professionals, and patients in the system. As we know, 2020 brought COVID, which actually helped integrated care in England, as providers were forced to work together in a global pandemic to treat and plan for their patients, essentially set up the process. Proposals for required ICSs in every state of the country were created to ensure integrated care systems were the standard to follow in healthcare. It was a shift from what we know to a new way of thinking and a new way of treating. Proposals on full funding were actually laid out with the real focus to a solid base amount provided to each ICS based on their population and based on cases. There was a focus on the fact that no funding could be taken away from each state. Finally, official advisory boards were enacted in every ICS that include physicians, professionals, advocates, and persons served. Additionally, patient support systems were cemented to provide proper resources and care to everyone 24/7. Finally, in 2021, it's when the legislation was confirmed and the white paper developed on integrated care in England. In April of 2021, all 42 parts of England were declared integrated care systems. And finally, July brought the official legislation to Parliament. So the next question is, how are ICSs deemed successful? And what does success even look like in the healthcare system? With an emphasis on using all funding, ICSs are not graded on the money they save, nor the money they bill. It's truly about how the people treated in the system are doing based on their cases, physician reviews, and their own perspectives. In shared decision-making, patients feel in control of their care, and it actually results in a 20% reduction of cost at hospital and emergent care. There's a continuous outreach in ICSs to patients through all points of care. They use surveys in the offices, questionnaires that are emailed, questionnaires in the offices, and conduct interviewing with all of their patients. This is the true report card that ICS grades their service and success on, coupled with patient success after their treatments. Again, patients must be informed and educated about integrated care systems and their own care. 40% of people say they don't understand information presented by a physician or how or why their plan of care exists the way that it does. NHS and ICS approach this by providing education to their patients from the beginning. They explain processes, ensure collaboration, and include the patient understanding above all else. It truly becomes a system that works for the people. These success rankings that ICS use can help us better form integrated care in our own state by using some of their best practices and adopting similar systems and in how we deem our own integrated care successful. So as Marianne was talking about, we conducted a survey, and this research was done in tandem with our own integrated care survey. The survey was distributed digitally and in paper form earlier this year. And in looking at other successful integrated care systems and listening to what the people in our own state said, we can better form our next steps towards implementation. So based on some great feedback on our first webinar, as well as the survey, we heard suggestions and concerns for the people in our state regarding integrated care. One thing that's not listed on here is that more than 50% of the people surveyed didn't know what integrated care was. And more than 80% of the people surveyed wanted more information and education on integrated care. In our open forum for feedback, the biggest thing that we heard was aspect of training for the providers in the system. We have to make sure we have an integrated care system where the providers are properly prepared to handle all cases across physical and behavioral health care, and that they are trained to refer and collaborate with other providers accordingly. Next from feedback is increasing the trust in providers to handle this type of collaborative care. This could benefit from proper training in the system, as well as education to all providers and patients about what integrated care is, as it doesn't mean your medical care doctor can now treat mental health crises. Rather, it's a collaboration. Things can be handled in conjunction during visit. There's also concern about continuity of care for the patients, where patients aren't forced to regularly repeat themselves about their cases, about their medical history, and about their care to different providers that they see. And also that they can be confident that all their providers are keyed into their care. Cost was an issue that came up several times in our feedback. What costs would be for the patients if their plan would change, what private insurance looks like, Medicaid, Medicare, so on, and what coverage looks like for everyone in the system in order for it to be all-inclusive. We also heard about the impacts that integrated care in our state would have on other systems that are currently integrated, and what that means for their own funding, for procurement, and for continuing treating the way that they do. Funding and how the budget works is another important thing that many people wanted to know about. If integrated care is written into Michigan law, how is it utilized? How is it spread across countries and sectors, counties and sectors? And what does that mean for our state and its own current systems? And finally, it was important for many of the participants that the system was person-centered and patient-focused. It had to consider the patients above politics, money, and everything else that gets in the way of proper integration and proper healthcare treatment. So that is my presentation on NHS and integrated care. I appreciate your time, and our research, as Marianne said, is ongoing to provide a real idea behind what we do to move forward in Michigan and how we can adopt some of these best practices that we've been researching in other integrated care systems. So our goal here is really to educate the people while making strides forward and advocating for them. Thank you so much.
Thank you, April, so much for sharing all that. The research that April did on behalf of MHAM and individuals across the state was really valuable, because our thought was that with all this discussion at the state level about integrated care, the concern was that people would A, have no idea what it was, and B, as you were talking about, April, how could anybody give feedback on something they don't particularly understand?
Yeah, we had a lot of surprising statistics that came from our survey. And even we presented the survey in the chat for the first webinar, and those followed the exact same statistics we gathered from our data. Most people don't know what integrated care is. They don't understand it, but they want to know. They want to know more, and they want to have the opportunity to make decisions for their own care.
Well, thank you for that, because one of the other points or reasons for doing these 3 webinars has been about increasing the voice of the people that have to live with whatever is created for them. That they should have meaningful input into what's created. And again, they can't do that if they don't know what it is. So thank you for all your research. Very, very helpful.
Thank you so much.
You're welcome. So I'm going to turn it over to Dr. Panero, who's going to talk about the paper from the National Council, and she's also going to talk about implementation.
So today, you can put, Kristen, you can put the first slide up.
Sure. Actually, we did have one question from Kate Dahlstrom.
Oh, okay.
Yeah, quick question for April. Are other countries in Europe doing similar programs?
Yeah, actually, in my research, I found a lot on Germany. They have a fantastic integrated care plan that's been in existence for quite some time, and their main focus is education and integrated care. So they actually start at the school level with children, and there's classes that 5 and 6-year-olds get to take about what integrated care means, what their visits are going to look like, what they should expect when they go to the doctor. So I really appreciated learning about Germany and everything that they do, because it really starts with focusing on the people understanding the healthcare.
Oh, great. Thanks. Thanks,
Yeah.
April.
So we're going to shift a little bit from the international discussion to the United States and Michigan. My objectives today is to review some of the materials that we discussed last week. We're going to have a few case presentations to show the different levels of integration. We're going to talk about implementation. And then we would like to have a really robust discussion about what's next for Michigan. So the why is so important, and it's important because it gives us the vision, the focus, the drive to overcome barriers. And it's important to really understand and embrace the why before you focus on the how to do it. These are 3 reasons for integrated care. April shared some other ones from England. But basically, it's that the mind and the body are one. And if you have chronic physical conditions, and you also have some co-occurring mood symptoms, which is very common, if your mood symptoms are not recognized, so they're untreated, or if they're undertreated, your outcome is going to be worse. The same if you have mental condition and you also suffer from some chronic conditions. If your chronic condition is not treated or is undertreated, you're not going to do as well emotionally. So in the previous slide, we mentioned serious mental illness and how those individuals, as we all know, die 15, 20, 25 years before their peers. There's been a lot of thought given as to why is that early mortality, are we able to modify that or not? This is a very simple study that was done in 2010 called the Primary Care Access Referral and Engagement Study. So they took a group of individuals who had SMI who were treated by behavioral health, and they divided them into 2 groups. So these were individuals that did not have primary care. One group received navigation support to access primary care. The second group received what we call care as usual. So they were encouraged to seek their primary care. They were given the advice as to why it was important, and they were given a list of primary care physicians that were accepting new patients. And not surprisingly, those that had extra help in connecting with primary care had improved engagement with their primary care over time. And they also had significant decrease in their cardiovascular risk factors. So Marianne mentioned this paper. We went through it in quite a bit of detail last time. This is published by the National Council and the Center of Excellence. And it's the Comprehensive Healthcare Integration Framework. Some people refer to CHI, and other people refer to the framework. They looked at, again, the components, what can we change to improve outcomes? And they came up with 7 domains, 8 if you include financial sustainability. So screening, you have to screen. If you're in behavioral health, you have to screen for medical conditions. If you're in a medical setting, physical health, you have to screen for mental conditions. Robust prevention and treatment of any condition that's present. Continuing monitoring and care management. April mentioned that. Self-management support, teaching the individuals how to manage their condition. Having teams support the individuals who are seeking treatment. And that linkage to resources, which April also mentioned, that's so important. And of course, you have to measure. So you have to have systematic measurement to make sure that you're doing what it is that you would like to do and that the outcomes are positive. But again, we can never, ever forget the purpose. Can't focus just on the domains. We have to remember the purpose. So we saw the slide at the last webinar. On the left-hand side is the different domains. And again, there's 7 of them, 8 if you include financial sustainability. There's the historical practice, integration level 1, 2, and 3 across the horizontal axis on the top. So here's what it looks like. This is an actual screenshot from the paper, and you can see that there's a lot of detail and examples for each level of integration. They call the levels of integration rather than level 1, 2, and 3 Level 1 screening and enhanced referral. Level 2 is care management. Level 3 is population health. I found those to be a little confusing because they overlap with some of the domains. So that's why I mainly focus on level 1, 2, and 3. So like I said, there's a lot of examples. Sometimes it's hard to, you get lost in the words. So I found it very helpful to take a 10,000 feet look at what separates the different levels of integration. And one of them is the population targeted, is all the efforts focus on just one individual at a time, or is there some population effort? The type of screening and intervention, the extent of care coordination, and April mentioned care coordination many, many times, how data is used, and again, which measures are monitored. We showed this again last time for the population. I already mentioned individual versus shared population across organizations. That would be level 3. Are the interventions basic or are they comprehensive? Is the coordination individually arranged one patient at a time? Or is there even shared electronic medical records? Data, is a focus on just individuals, or are you doing population management? And measures or metrics is really important. In level 1 of integration, you're really looking at processes. So, is the blood pressure being taken? Is the blood work being done? Versus looking at outcomes. How are the consumers or the patients doing in level 3? Now, it's important to understand that to reach level 3, you have to do everything in level 1 as well as level 2. And what's required for level 3. So you can't just hop over to level 3. So looking again at level 3, population, and what I found really, really important is that both the behavioral health and the physical health systems are held accountable for both engagement and outcomes. The level of intervention, as we mentioned, is very comprehensive. Lots of coordination, EMR interoperability, so the consumer, the patient, they don't have to tell their story over and over again. There's no gaps in the information. And in order for patients to feel comfortable with this, there has to be a lot of respect and trust and education of the providers. One treatment plan across all settings, so you're getting the same message, and you're having a whole team supporting the patient to build all the steps or go through all the steps they need to reach their goals. Level 3, with the use of data, they really look at who needs the most support, so that poor graduate there at the bottom of the slide, he's going to need a lot more support to reach his goals than the gentleman that's on top of the fast car. And it's important that the gentleman at the bottom of the slide gets the resources that he needs. Metrics, focusing on patient outcome. So is there improvement in function, the patient reaching their goals, and is, as a result, do you have increased participation in the community and with family and work? So I'm just going to go through some cases, and I'd like you to think about what level of integration the case is. And I think that would be helpful because as we seek our own care, we may be thinking about what level of integration our behavioral health center or our medical physician is at. So this is a 28-year-old single woman, mother of 2. She comes to the behavioral health clinic complaining of anxiety and low energy. During the interview, she asked for water, explaining that she has been very thirsty. So scenario 1, when she's asked more about her anxiety, she states that she fears she may lose her housing as she has not been able to work all of her shifts and has not kept up with her rent. Her case manager is concerned about her low energy and increased thirst and offers to help her make an appointment with her doctor. When the consumer states that she does not have one, she's given a list of local primary care providers. So what level of integration do you feel this behavioral health center is at?
We have a level 1.
Okay, anybody else? It's okay to guess.
Lots of ones coming in.
This is actually the historic, so they haven't even started to integrate. So there's no screening done. and there's no coordination with the primary care and no assistance. And she's just giving a list. And my CMH used to be like this. So the same young woman, during her assessment, she screened for common physical health conditions and risk factors. In addition to low energy and increased thirst, she's found to have high blood pressure, she smokes, is overweight, and she has a positive family history for diabetes. Her referral to primary care is facilitated, and she agrees to have her health screen information sent prior to her appointment. What level? Just take a guess.
There's a 1 in there.
Mhm.
No EMR, only screening.
Yes.
We have a 2 in there. We have another 1.
Okay, so this is actually 1. There's some level of screening. It's basic screening and basic sharing of information. But you can see how she would do much better in the second scenario than she's apt to do in the first scenario. In addition to scenario 2, her physical health screen is more extensive. She's introduced to a team members who will be assisting her, including supportive employment and housing specialists that she's able to access if she needs. Her team assures that she has transportation to her primary care appointment, and the workup results from her primary care are going to be shared and entered into the record at the Behavioral Health Center. Her health goals are also entered into a registry so she can be monitored and not fall through the cracks. What level integration? Okay, so this is level 2, much more extensive screening. She has a team support, and there's much more coordination with her primary care, and her goals are entered into a registry and the team is following. So there's that continuing monitoring and care management. Okay, so if you go back to the framework, and I'm not going to spend time looking at this because of the interest in the time that we have left, you'd be able to see the different elements of the different scenarios. So this is a different scenario. It's a 22-year-old college student. She sees her primary care. She's complaining of difficulty with sleep, concentration, and anxiety. So she's in her primary care office. She's screened for depression, and the results show some moderate depression. When asked about her anxiety, she relates fears that her friends are able to read her mind or her thoughts, and she reluctantly gives several examples. She becomes more anxious as the appointment progresses. What should happen next in a fully integrated behavioral health and physical health system? So the primary care is left with this young woman. What's the primary care physician going to do? Or what do we suspect the diagnosis might be? What's happening to her?
It says there should be immediate access to a behavioral health specialist.
Right.
Someone wrote schizophrenia.
Right, so she's having probably first episode psychosis. She's developing schizophrenia. Immediate treatment is extremely important and it impacts her outcome. Access to behavioral health services is paramount. If she's becoming more and more anxious, and she might even leave the office. So the primary care gets on the phone and asks for help. It would be wonderful if somebody from the Behavioral Health Center could come to the office, speak with her, meet with her, make a connection, possibly a peer that can share some experiences to help her develop that relationship to follow up with treatment. Seamless handoff. Okay, so joint accountability for engagement. So even though she's in primary care, behavioral health has a responsibility to engage her. You can't just ask her to go to a behavioral health center. Okay, Mr. B is a 45-year-old male with schizophrenia. He has high blood pressure, diabetes, and is overweight. His nurse discusses with him the importance of healthy eating and exercise, and he's giving pamphlets, which the nurse reviews with him. He's also encouraged to see his primary care. What level would you say this is? just a guess. Level 1.
Yeah,
Um,
1-0. Another, who is he seeing?
Right, he's in behavioral health. So one could argue that it is, level 0 or level 1. Behavioral health does have some information on healthy eating and exercise that they're sharing, but the level of education and help for him is minimal. So same gentleman, his psychiatrist calls his primary care to discuss options to decrease Mr. B's risk for cardiovascular disease. Mr. B's behavioral health team discusses his history in response to other antipsychotic medications and the need to increase support should the medications need to be changed because of his weight gain. Mr. B meets with his team nurse and case manager to discuss his food insecurity. He's connected with a food bank and with a specific individual at the food bank that's looking forward to meeting him. The team nurse helps him with behavioral activation and action plan that's designed with him, of course, that he can achieve and have success with. His primary care assesses him to see if he's a candidate for an appetite suppressant. His peer calls him between appointments to provide support and discusses barriers. The behavioral health clinic also has a population health analytics, and the appropriate resources are allocated. Mr. B's PCP and behavioral health clinics share the same EMR. So this is full integration. And you can see that his outcome is going to be significantly different than in scenario 1. So payers meet with the local health system, the behavioral health centers and agencies addressing social determinants of health to discuss data and population health management. The data shows that behavioral health patients have a lower rate of cancer screening procedures and increased rate of uncontrolled diabetes. The group undertakes a quality improvement process and discusses root cause analysis. This, of course, is level 3, is extremely important to be able to do this type of community needs analysis. And it's true that behavioral health patients have a lower rate of cancer screening as well as an increased rate of uncontrolled diabetes. So implementation, the framework is designed so that you're able to measure where you are. So it can be a measuring instrument, measure where you are in integration. And it's very important to be very honest as you go through it. And then you pick the domain that you feel you can increase the level of integration and that it would have the most impact with your population. So then you identify the next steps. You delineate which metrics you're going to follow to make sure that you did increase your level of integration and quality improvement processes should you fall short. So the implementation is actually very, very simple with this framework. You look where you're at, you can choose one domain, 2 or 3, go to the next level, see what needs to be done. Evidence-based care for prevention and intervention of common physical health conditions. And I found this to be extremely helpful as I was redesigning the health services in my agency. Before we were doing very basic screening, we decided instead to do a very robust screening for physical health conditions. We got some pushback that it was taking too much time, too much nursing time, but eventually everybody was able to see the importance of that. The other thing that is noted there is the amount of training. So under level 1, there's just basic training for the providers. And that's, not only the psychiatric staff, but the nursing staff and the case holders. And under level 2, there towards the bottom is in-depth training. So we're currently going through a process of in-depth training of all of our staff. And it's been difficult to find that training in physical health, which has been extremely interesting. So that's one of the barriers that there are in Michigan. People talk about value. As you move from one level of integration to another, you're building value. And value between a provider and a payer is improvement in the population health outcome over the expenditure. That's not necessarily what the patient sees as value. They want to get quality care and they want to get the support so they can have excellent outcomes. Hospitals are rated in quality. You can often, is this a 5-star hospital or, is this 4th in the country? Surgeons, you can look up their metrics as far as rate of complications and successful surgeries. But currently we don't have any way in behavioral health for a patient or a consumer to choose where's the best place to go. But the role of the payer is not just passing money or paying for services. Like we mentioned before, they have a lot of data. They can convene large groups like health systems in order to do some population health analysis. And we're back to our 3-legged stool that we talked about in the first webinar, where you have the patient at the center. Everything has to be patient-centered. You have behavioral health and physical health closely connected and coordinated, as well as the payer. And the agencies that deal with social determinants of health are closely connected with behavioral health as well as physical health. So you can have severe diabetes, you lost your job, you're living out of your car, you don't have any behavioral health symptoms currently, but that individual is not going to have good outcome unless they can access help for their homelessness. National Council has a lot of webinars coming up on this framework. Their next webinar is on May 25th. And they also have a whole series coming up on perinatal health and the importance of integration, which I think would be fascinating. So that occurs on May 10th. I'd like to talk about, what would be our vision? Who are the stakeholders that we may want to get together? And I just listened some of the stakeholders there. And what would be our next steps? So April, take it away. And Marianne.
Well, thank you, Dr. Pinero, for your presentation. So I'm curious, before I talk about some of the policy implications for Michigan, I'm curious to see, does anybody have any feedback about Dr. Pinero's presentation or any of the things that she talked about that are illustrative of what constitutes level 3 integrated care, which is full integration? Any thoughts about that? Here's kind of a policy perspective on all of this. The thing that has become very clear to us at MHAM, one of the things that's really lacking in our state is a strategy around what does integrated care look like across all health systems, not just the public system, but across public and private systems, and not just behavioral health, but physical health as well. One of the things that, we believe needs to happen, there needs to be some leadership. There should really be a coalition of payers, all the stakeholders that Dr. Pinero mentioned in her last slide, including the end user, should all be part of a conversation that looks at what should our integrated care policy be in the state of Michigan and how do we get there? I've heard, and I know I've said this, I believe at one of the last webinars, previous webinars, is that in speaking with an individual from Mental Health America, which is our national organization, is that we are one of the last in the country and last in the nation to have any sort of strategy or, effort around integrated care. There is no definition of integrated care in statute. There's no recommendation regarding a model. And I think one of the reasons why we were so excited for this paper to come out, although Dr. Pinero frequently references a New York paper that mirrors pretty much what this paper from the National Council says. What MHAM would like to do is bring both of these papers to the attention of policymakers and others and say, where's the leadership around bringing together all the stakeholders so that there can be a cogent, non-political discussion about integrated care that's completely focused on what's in the best interest of the people that need the integrated care. I think at some point we're all going to need integrated care because 90% of all disabilities are acquired. And if we live long enough, we will probably acquire a disability, whether it be hard of hearing, vision loss, ambulatory issues, whatever. The bottom line is at some point, we're all going to need it. And rather than having people have to access different siloed systems as their conditions deteriorate, wouldn't it make more sense to have everything available in a very coordinated, comprehensive way where there's literally no wrong door? When Dr. Pinero was talking about the scenario with the individual who clearly was experiencing first episode psychosis, in my mind, the best response would be to have the behavioral health professional, the psychiatrist, the clinician on site so that the individual could be assessed immediately and action could be taken then and there, as opposed to what we currently possessed, which is primary care doctor sees the person has psychosis. Typically it's, well, I guess we need to send you to the emergency room to be evaluated. Well, that's only evaluation for inpatient, which is what might not be needed. Person will probably not be prescribed any psychiatric medications in a traditional emergency room. And so what happens, the person ends up pretty frustrated by the experience. So from a policy perspective, I think the most important piece is increasing collaboration across all the systems, putting together a coalition of behavioral health, healthcare providers, other providers, as Dr. Pinero indicated, who address the social determinants of health. So that would be housing providers, food banks, that would include providers of transportation, community support services, community action agencies, the list goes on and on. It really needs to be a community approach, particularly when we're looking at some of the realities that people with more severe mental health and behavioral health conditions struggle with, where they lack stable housing, they lack food, they lack access to transportation, they lack access to primary care. That's where good, solid case management comes in. And I think the other thing that I want to say for the Mental Health Association is that at the end of the day, all healthcare is healthcare. There's no distinction between behavioral health or physical health. It's all equally important. I think the discussion around whether or not to integrate care will be a lot clearer if we stop viewing the brain or the mind separate from the body. And we realize it's all interconnected, and we know this. And we stop thinking about it in such a way that there's this dichotomy that exists. There is no dichotomy. It's all interconnected. So those would be some policy considerations. MHAM, we have a subcommittee of our public policy committee that is taking a long look at behavioral health integration. And how do we foster a coalition across the state? And how do we also continue the conversation, which is something we'd like to see all of you do, is to continue the conversation. I don't believe that this will be our last webinar. We would like for it not to be our last webinar, because I don't think the conversation about integrated care is going to end. The challenge is to have it not just happening at the legislature. It needs to really be had at the level of all the behavioral health, physical health, and all the stakeholders previously mentioned. I see one that says RCMH is partnering with FQHCs. For those of you who don't know, an FQHC is a federally qualified health center. A lot of CMHs are actually partnering with FQHCs, but Dr. Pinero, do you want to respond to that?
Sure. Integrated care has to be wider than that, because otherwise, if it's one CMH and one FQHC, you can provide excellent care for that shared population. But what about the rest of the community? Not all behavioral health center individuals go to FQHCs. Some of them have long-term relationships with their own primary care physicians. In central Michigan, the majority of our consumers have long-term relationships with their primary care physicians, and they don't go to an FQHC. So it has to be throughout, and it has to be not Medicaid specific. So it needs to be insurance blind.
The final question is, what are agencies doing to provide transportation? I think transportation is a huge problem, particularly in rural communities where there's an access of public transportation. What I will say is that when I was the director of a rural CMH, we ended up paying a lot of dollars towards transportation to get our consumers to and from the clinic, because the clinic was located in a very rural area. But transportation, just like housing and food insecurity, is a huge problem in our state and really across the United States. Those types of issues are larger public policy issues that need to be really looked at and resolved as well. Well, thank you, everybody, for participating this evening in this presentation. We really appreciate you being a part of this conversation. Please look out for potentially some other, maybe one or a few more webinars. If you have questions, please feel free to let us know. And also, want to thank you for being here. And of course, what our motto is, mental health matters every day. And really happy to be doing this in the month of May, which is Mental Health Month. So thank you for being here and have a great evening.